Hi, everybody. I'm Jessica Shore. I am the Director of Clinical Affairs and Advocacy here at CurePSP, and it is my pleasure to welcome you to the second Ask the Expert webinar of the year. We broke a record of our webinars with over 500 registrations for this one. So that really reinforces to me the importance of today's topic. But before I introduce our speaker, if you've watched our webinars before, you know that I need to share a few housekeeping items first. This program will be about an hour long, although it's a big, important topic, but we're going to try to keep it as close to an hour as possible. And that time will include the presentation as well as a question and answer session. We are recording this webinar live, but it will be archived on Facebook and on our YouTube channel for anyone to view later on. If you had registered for this webinar, you will receive an email after with today's slides. And if you're watching this live, they're going to put that in the chat for you as well, so you can have our speaker's slides after this. Many of your questions will likely be addressed throughout the presentation. And as always, unfortunately, we realistically can't get to everyone's questions, but you're welcome to type questions into the chat section of the platform that you're using to view this live. We're also going to be referring to many of the questions that folks submitted during registration. And I always have to say, too, that information shared in this webinar is really not meant to be medical advice. We recommend not sharing personal health information in the chat, and we encourage you to talk to your healthcare team if you have specific and personal medical concerns and questions. And also, if you're watching this live, we always enjoy when you use the comment box to say hi and where you're tuning in from. Today, I am joining you from my home in Durham, North Carolina, and I already see that a number of you have been doing that in the chat. We have people joining us from all over, which is amazing. And lastly, I want to emphasize that we always do our best to create educational programs like this to be as relevant as possible for the whole community, regardless of someone's connection or stage of progressive supranuclear palsy, corticobasal degeneration, or multiple system atrophy. And also, because of today's particular topic, some of what will be discussed around disease progression is tough, and so that can trigger feelings of fear or grief, and we want to normalize that and allow space for it. But no matter what, it's our hope that you can leave this program today with at least one helpful takeaway or new piece of information that you can use in your journey. At this time, I would like to introduce our speaker, Dr. Jori Fleisher. Hey, Dr. Fleisher.
Hey, Jessica.
Always great to see you. Dr. Fleisher is the director of the CurePSP Center of Care at Rush University in Chicago, where she leads the Advanced Interdisciplinary Movement Disorders Supportive Care Clinic, called the AIMS Clinic for short, because that's a mouthful. And she also really has a passion for studying models of innovative and person-centered care delivery. I've had the pleasure of knowing and collaborating with her for a number of years at this point, from before my time at CurePSP. Questions about what to expect with disease progression are really among the most common that clinicians and also that CurePSP staff and volunteers and support group leaders receive from the community. We don't have all the answers. We know that everyone is different, but I chose today's topic around navigating advancing symptoms and stages of PSP, CBD, and MSA, really in an effort to offer more resources and guidance for this. And I invited Dr. Fleisher as our expert speaker because, knowing her passion and compassion, I really couldn't think of a better person to address this topic. So great for you to be here. Thank you. And I will let you take it from here.
Thank you so much, Jessica, for the really kind introduction, and to everyone for joining in live, and for those who are watching this later recorded. Thank you so much for taking this step, and hopefully you leave with some pearls today that are helpful and hopeful. So this is a topic that is really near and dear to my heart, which is navigating advanced symptoms and stages of these conditions: PSP or progressive supranuclear palsy, CBS or corticobasal syndrome, and multiple system atrophy or MSA. So a couple of things as we get talking. So number one, sometimes I use humor in my talks. I want to be really clear that there is nothing funny about these diseases, but rather humor is a really important coping mechanism for people living with these conditions, for families, for care partners, for healthcare professionals. So I hope that there's something in here that makes you smile, maybe makes you laugh if we're lucky. Sort of, I always like to have sort of a do not panic, because we're going to talk about a lot of different things. No one gets all of the things, but I want to present all of this to you so that if this resonates for you, your loved one, someone that you're talking with in a support group, you have information at your fingertips. So, why am I showing you a menu of the Cheesecake Factory? So this gets at this point of not everything we talk about today will apply. These conditions, even if we were just talking about one condition at a time, but particularly when we talk about all three, PSP, MSA, CBS, no one that you meet who has that same diagnosis that you have or that your loved one has will have exactly the same journey. And my analogy for this is, if you're familiar with the Cheesecake Factory, which legendarily has a menu that's like that thick, you could go to that restaurant once a week for an entire year. You could go with your neighbor, and the two of you would never get exactly the same thing off of that menu because there's so much there. And these conditions are similar to that Cheesecake Factory analogy. So just because we talk about something today does not mean that it will happen to you or your loved one, but we want you to be empowered. And we're talking about navigating advanced symptoms and as these diseases progress. And these are slowly progressive neurologic conditions. But today's Wednesday, as we're recording this, as we get towards the end of the week, I know that I need to carve out a chunk of my Friday afternoon because I will get all the messages of all kinds of things going wrong on a Friday, right? And so it is very true that people with neurologic disease will sometimes have sudden changes. And what I want to make sure is really clear is that these diseases underneath are slowly progressive. And a person's brain and body is always compensating to some extent. And as soon as there's an infection, most often, or severe constipation, or anything else that's really a shock to the person's system, something else that's out of whack, the compensation that's been going on goes away. And we see a sudden worsening of the PSP, MSA, corticobasal symptoms. It's not that a population of brain cells has suddenly died off at 4:30 on Friday. That doesn't happen. But the compensation goes away if something else is brewing. So if you or your loved one have sudden changes, regardless of what point you are in your journey, keep in mind that, we always want to think about what is going on. So that could be an abrupt change in mobility, that medicines don't seem to be working the way that they were, or a person who wasn't falling is suddenly falling a lot, or they're stumbling a lot one day. They're choking. They're having that freezing of gait where their feet are getting stuck and they can't move, or they're more confused, or they're hallucinating where they were not before. If those things are going on, we want to think about what is causing it. And it's usually something treatable and reversible. So if my residents or my fellows, any of our trainees, if our nurses say, Mrs. So-and-so called in and this is happening, it is a urine infection until proven otherwise, because these are very, very common conditions in people with PSP, MSA, CBS, and they're treatable, and it's often missed. So always think about a urinary tract infection, and think about it even if you or your loved one is not having urinary symptoms. In people with neurologic disease, the first symptom of something else is often a worsening of their neurologic condition. And sometimes that requires a lot of advocacy on your part, on families' parts, to say to an urgent care doc, to say to an emergency room nurse, no, my urine is the same color as it usually is, but this is what happens when I have a UTI. This is what happens when she has pneumonia. She gets more confused. So urinary tract infections, pneumonia, other infections, COVID, flu, all of these things. And other infections like dental abscesses. So people often kind of fall behind on their dental care when they have neurologic disease. And so dental infections can be a source of sudden changes. If someone has diabetes and they're prone to foot infections, always looking at the feet to see if there's something going on, that could cause a sudden change in PSP, MSA, corticobasal symptoms. And these other things listed here. The other ones to think about are any medications that were missed, any new medications that were added when there's been a sudden change. If the medicine suddenly looks different, you picked up a refill and it went from being a yellow pill to a blue pill, that may be a reason. It may have changed. And sometimes medicines are added on by other folks outside of neurology that the neurologist might not know of, primary care might not know about, and those could be playing a role. Other things also are over-the-counter pain, nighttime pain medicines and cough and cold medicines. Many of those have ingredients in them that are particularly dangerous for people with neurologic illness. So anything that says severe, plus, max, DM, PE, any of the PM pain medicines. It's not the pain medicine that's the issue. It's the PM thing that's the issue. So if your loved one takes something for pain and they're really confused the next day or really stumbling, think about that. Let your healthcare provider know about that. Okay, so with the sudden changes out of the way, we're going to talk through stages. And I think this is one of the most common questions that I get in clinics, seeing people with these conditions all the time. And the simple answer to what stage is my loved one in, if we're talking about PSP, if we're talking about MSA or corticobasal, is there really is not a good disease-specific, accepted, widely used staging system for any of these conditions. Are there some out there? Yes. Are they used frequently? Not really. So I'll tell you a little bit about those. So Dr. Larry Golby, who's heavily involved in CurePSP and is a leader in this field, he has published a staging system. And it really, all these staging systems kind of rely on the physician, the healthcare professional kind of ticking different boxes to say, well, the person has this, but they don't have this. Well, and they sort of have this one and this risk factor. And so that staging system hinges on trouble with swallowing and swallowing studies where objectively a person's been seen to have trouble with swallowing both food and water, ability to walk with assistance, with a walker or a cane, with another person helping or not, and the ability to stand up from a chair. And those couple of items, plus the PSP rating scale, which is part of the examination that a neurologist may do, that helps us predict survival in certain research studies, but doesn't tend to be used very often in clinical practice. There's just not enough evidence behind it that tells us it's reliable yet. Similarly, in MSA, there are publications about using age at onset of symptoms, gender, subtype of MSA, so whether there's more Parkinsonism or whether there's more cerebellar dysfunction, so balance and coordination, and sort of how long and when a person has autonomic symptoms like constipation, blood pressure drops, urinary issues, and their movement symptoms. But how useful those risk factors are varies from one study to the next. And in corticobasal syndrome, to my knowledge, we don't have any recognized staging system yet. So what do we do with this? I will tell you what I do in my own clinic where we focus on people with advanced or late stage Parkinsonism. There's a group from Europe called the CLASP study, and these investigators have really defined this idea of late stage Parkinsonism, which is not specific to any one diagnosis, but says people who have late stage Parkinsonism tend to have more trouble with swallowing, more trouble with balance, with falls, more trouble with urinary, bowel, bladder kind of issues, more sort of central issues, more cognitive issues, as whichever diagnosis they have is progressing over time. And so if we're seeing people with sort of that combination of symptoms, then we sort of think about, well, we're more in a late stage and go from there. And so We don't have stages that are specific to the diseases to hinge our hats on, right? But what we do have is we can talk through the different symptoms that may crop up. And what I want you to take away from this is while there are many symptoms, there are many of them that are treatable. So I wish that we had cures. I wish that we had specific treatments for these underlying diagnoses. Not yet, but many people are working on this. But what we do have are specific treatments for specific symptoms. So as a movement disorders neurologist, people come to me and think, okay, well, maybe we'll talk about tremor, we'll talk about walking. But what's really key in these diagnoses is that there's so much more than just movement. There's a lot of evidence that the needs of people with these advanced conditions far exceeds mobility. So this slide is taken from one study, echoes some other studies, where they asked people with sort of late stage Parkinsonism, what are your needs? And not surprisingly, these are movement disorders. So trouble with mobility, trouble with coordination, impaired speech, really common. But pain can be really common. Trouble with activities of daily living, like getting dressed, hygiene, toileting, trouble with the autonomic nervous system, trouble with cognition. All of these things are really common. Social issues, social isolation. We saw this certainly during lockdown for COVID, but one of the things that breaks my heart the most is when we started reaching out to our most affected people during COVID lockdown and saying, how are you holding up? Are you getting what you need? So many of my families living with PSP, MSA, CBS said, Dr. Fleisher, this really isn't all that different from our usual. We don't go out much. We have stuff delivered because it's too hard to XYZ. We're really isolated to start, so this isn't really anything new. So that social isolation is huge, both for people living with the diagnosis and for care partners. So there's so many needs here. For the sake of time, I'm going to skip over that strategy. But what I do want to say, I'm not going to talk a lot about movement symptoms, but I'm going to talk a little bit about thinking about managing those medications, because as time goes on, for many people, they may have been given therapies related to dopamine. So most often something like carbidopa, levodopa. And in many people in these conditions, those drugs can be very helpful. Sometimes we have to push to much higher doses than we would in someone with regular old Parkinson's disease, but we try them. It's still our most powerful, safest medication that we have. But as time goes on, something that's very common, particularly in people with PSP, is trouble with swallowing pills and pocketing of pills. So before we conclude that medicine doesn't work anymore, we want to make sure that the medicine is actually being swallowed. So it's very common for people to what's called pocket pills, which means the person puts the pill in their mouth, looks like they swallow, and then their care partner might come by an hour later and see the pill on the table or find pills on the floor. And the person they're not doing it intentionally, but it kind of sits on the side of their mouth in their cheeks in a little pocket and then kind of falls out later. So we always want to watch for that pocketing of pills before we conclude that the medicine isn't effective. And sometimes people have a very hard time swallowing. So if someone is on levodopa and the medicine's been effective, we don't want to stop it abruptly, because that can actually lead to a medication withdrawal syndrome, and people can have very severe symptoms if they're going from being on a pretty solid dose to nothing. So if someone has a lot of trouble swallowing, we may want to crush their levodopa, dissolve it in fluid, see if they can do it that way. Sometimes people are in the hospital. For example, they might have pneumonia, and they may not be able to take things by mouth. They might be unsafe to swallow. Sometimes the team will then put in a tube that goes down the back of the throat through the nose into the stomach to help deliver nutrition and to help deliver pills. Those types of tubes, called a nasogastric tube, those are temporary. And what often comes up is if someone continues to have trouble swallowing, either their medication or their food, do we put in a permanent tube to help with nutrition? And so a permanent tube for feeding or for medications is often referred to as a PEG tube. And that's something that avoids going through the nose and mouth and goes through the stomach wall, through the abdominal wall, to be able to deliver nutrition and medications directly into the GI tract. So those are things that can come up. All of the dopamine-related medications can be given through both those types of tubes, and that often requires involving a team of healthcare professionals. So pharmacists, speech-language pathologists, dietitians, inpatient hospital teams, outpatient neurology teams, hospice teams, and caregivers can all be part of that conversation and be a resource if swallowing issues are coming up, especially around medications. So as I mentioned, we just want to make sure we don't have any sudden stops in medication because that can be a big problem. Another movement problem is dystonia. And Jessica and I were just talking about this before we went live with you, so dystonia is an abnormal contraction of the muscles. We think about it as sort of two or more groups of muscles are kind of working against each other instead of working together. So sometimes dystonia is a twisting movement. Dystonia can be of the neck. Sometimes in PSP, we often see dystonia with the neck tilted backwards. In MSA, we often see dystonia with the neck tilted forwards. And we can see dystonia of the arms and limbs, especially in corticobasal syndrome. We can see very stiff limbs. There are oral medications that can be used to try to help with dystonia. And one of our most effective treatments is actually using botulinum toxin injections, commonly referred to as Botox, but there are many different brands. And those are our most effective treatments because they have very few other side effects. We sort of put that into the muscles that are affected and it stays where we put it. You don't have to take a pill every single day, but the medicine, the Botox, works for a period of time and then wears off, typically around 3 months or so. But those are some of our options for treating people with dystonia. We also think heavily about physical therapy and occupational therapy, not necessarily to make the dystonia go away, but to train people sort of how do you work around it. So if a hand is doing this, how can you compensate in a different way? And that's where our physical therapy and occupational therapy colleagues can be tremendously helpful. I want to point out this symptom, which is typically not bothersome, but can be scary because people don't know what it is and whether it's related. So myoclonus is a very fancy word for lightning fast jerks of the muscles. So all of us have myoclonus. If you've ever had hiccups, that's myoclonus. If you've ever had that experience of falling asleep and you're in bed and you suddenly kind of jump yourself awake, that's myoclonus. That's all normal myoclonus. But people with corticobasal syndrome especially, and occasionally some folks with PSP, can have more jumpy, jerky myoclonic movements of their body, or just be sort of more prone to startling more easily. This is not something that we need to treat unless it's really bothersome to the person who's living with it. But if it is, there are medicines that we can use to treat it, and there are medicines that people could be on for other reasons, like gabapentin or pregabalin, that can sometimes make myoclonus worse. So if this is something that's going on with you or your loved one, just know that we can do something about it if it's bothersome. I mentioned in that slide earlier where we talked about sort of all of the needs, that pain is really common. And I will tell you, as someone who's been in practice for a bit, but hopefully not super, super long, that back in medical school, pain was not even discussed as a part of regular old Parkinson's disease, let alone any of these conditions. But as people have studied this, we've learned that pain is the 6th most bothersome symptom in one study of people with late-stage Parkinsonism, so all comers across diseases. And there are 4 common types of pain. There's sort of musculoskeletal, which is achy, almost arthritic kind of pain, bony pain, muscly pain. Dystonic pain, which is when those muscles are cramping and pulling against each other. There's radicular or neuropathic pain, which is sharp, shooty, sciatica-like pain. If people have had carpal tunnel, it can be something like that. And then central pain, which is a vague kind of everywhere feels uncomfortable. It's very hard to describe. And for all of these common pain types, there are things we can do. So we don't have time today to go into all of the different ways to sort of treat pain, but I want you to come away from this knowing that pain is not something that absolutely needs to be suffered through. It may be part of these diagnoses, but it is treatable. So physical therapy and exercise, and that exercise can be almost anything. It is what you or your loved one can do to improve mobility and prevent contractures, the muscles getting fixed in a position. We can tailor medication therapy to the type of pain. And sometimes something as simple as, if you don't have liver problems or kidney problems, so that acetaminophen or Tylenol or NSAIDs like ibuprofen or Advil, if those are safe, and again, talk with your particular healthcare professionals, instead of waiting until pain gets bad, having a schedule of pain medications, over-the-counter pain medications that you take at specific times throughout the day to get ahead of it rather than chase it, that can be tremendously helpful. For stiffness and sort of the tightness that can come, topical things, I call them the stinky category. So that's anything menthol and capsaicin, that's icy hot, Bengay, Aspercreme, Tiger Balm. If it's stinky, it's in this category. And then things like diclofenac gel, which goes by Voltaren, that's sort of like an ibuprofen, but in a gel form. Those can be put on a schedule and used for people with pain. And sometimes we forget the really simple stuff. So heat packs, ice packs, microwavable things that go around the neck, conform to joints. And then for people whose hands are kind of balling up, or we're having fists a lot of the time, keeping a stress ball, so something simple like this, keeping a stress ball, keeping a small stuffed animal, keeping a rolled up washcloth or a towel in that loved one's hand can help so that they're not digging their nails in. And that's another reason, if we're having trouble and we're digging our nails into the hand and you can't open that hand to get it clean, that's another time where botulinum toxin injections can be helpful. It won't give back function, but it can let you open that hand to make sure the person isn't harming themselves, isn't getting an infection there. And when we talk about pain for so long, and this is particularly true with more late stage disease, our medical model thinks about physical sources of pain. And that's not the whole story. So pain, sort of this concept of total pain, takes into account physical pain, psychological pain, social, and spiritual, all together. And so an overlooked source of pain is often spiritual distress. And this is not related to any one religion, any one practice, but a person's spiritual beliefs often influence their understanding of their illness, of their decision-making. And being at peace, whatever that looks like for a person, has actually been studied and found to be associated with an increased sense of hope and optimism. And for many people, dealing with a life-altering serious illness can be a huge source of spiritual or existential distress. There's often a lot of guilt, a lot of, why is this happening to me? What did I do to make this happen? I've been a good person, so why? And so talking with someone, a member of your faith community, if that resonates with you, talking with a hospital chaplain, talking with other community members, with family or friends, can be very helpful for addressing this other source of pain that we overlook far too much. And it's clearly a part of living with a serious illness. Something I'll talk about a little bit later in the talk are advance directives, right? And so why would legal documents have anything to do with spiritual distress? Advance directives, I think of as a way of asserting control and having a sense of closure and offering a legacy for yourself, for loved ones, for family and friends. And so we'll get into that at the end, but sometimes that can be a big relief for people when they know that they've sort of put their wishes onto paper. There's sort of a sense of, okay, I'm a little bit more at peace with whatever's coming. And then I want to bring your attention to this idea of dignity therapy. This is something that we've been fortunate enough in our Ames clinic. We have an amazing chaplain, Dirk Labouchine, and he tested this intervention that's been studied in cancer and other conditions called dignity therapy. And it's a fancy way of saying someone interviews a person who's living with a serious illness and is asking them structured questions and recording it, essentially saying, tell me about you, tell me about your life. What's important to you? Are there things that are left undone or unsaid that you want to get done, right? Are there things you want to make sure your family knows about you? and recording that, transcribing that, and putting that into a legacy document that the person then gets back and can share with whoever they want. And we've found that to be really helpful. The response that our patients and families have had for that's really helpful. It can be hard to find and access, but there are actually some commercial services that do something like this. So not endorsing anything, but I had a patient and family tell me about something called Storyworth, which essentially prompts people with questions about their life, and they sort of record all that, and then you can kind of have it all printed out for you in a book. This is also a great project to do with kids or grandkids, have someone record a conversation and be able to share that. Other things that go on include deconditioning. And what is deconditioning? This is a fancy word for saying kind of losing some of the strength, losing some of the mobility as time goes on. And so if someone has had an illness, if someone has had some sudden decline, I always tell my folks that for every day a person with Parkinsonism of any kind is in the hospital, figure 1 week to recover. It's sort of a 7 days of recovery for every 1 day in the hospital ratio. And if you're sitting in the hospital or you're sick at home, you're recovering from COVID or the flu, you're not moving, you're not doing whatever your normal is, it will take time to recover, to get back to that baseline. And so physical therapy, exercise, keeping that range of motion, even if it's a loved one, moving the person around just a little bit, all of that counts. All of that helps. Something that can come up as time goes on, and I think of as related to mobility, is as we lose mobility, as we become deconditioned, people can often develop pressure wounds. So what that means is an area of damage to the skin or underlying tissue, usually over a bony area. So most commonly that's over the sacrum, sort of the bottom of the spine and the buttocks, over the heels, sometimes over the elbows. And this is often due to pressure or immobility. As people are progressing, they may be losing weight. And so the skin may be more fragile. There's just less cushion between the bones and the pressure that's being placed. And if someone needs help with turning or moving in bed or in a chair, that friction and shear force puts a lot of stress on the skin, and it can start to break down. So sometimes this just looks like a red mark that kind of won't go away. Sometimes this turns into more of a wound. We want to really be on the lookout for things like this because they can be very treatable early and very difficult to treat if we let it go too far. And there are team members who can help with this. So we think about reducing or eliminating factors that are contributing, like proper positioning, proper support, getting a custom wheelchair if we need that, getting special pillows or seating elements. And then wound care. So many places will have wound care services or wound care nurses or teams or outpatient wound care clinics that can help and come up with specific bandages or specific treatments to heal those wounds so that a person doesn't get an infection. And as we do that, making sure that we're controlling any pain. We're going to switch gear away from sort of movement-related things to some of the non-movement symptoms. So insomnia is incredibly common. There are entire talks on sleep dysfunction in these diseases. I'm not going to go into all the whats and the whys, but does it happen? Yes. Are there things we can do? Yes. Are there sometimes medicines that are contributing? Absolutely. Are there medicines we can use to treat it? For sure. And so a lot of treating insomnia requires a visit with your healthcare team to figure out what does your sleep schedule look like? What's waking you up? Is it stiffness? Is it the bladder? Is it the bowel? Is it, irregular sleep schedules? What is it? Because specifically then, if we know what's causing it, we can treat it more effectively. Sometimes we need to get a sleep study to rule out sleep apnea. So if you hear your loved one gasping, or if you recognize yourself that you're waking up and gasping for air, snoring, often a CPAP can be very, very helpful. We want to make sure people are using good sleep hygiene. So avoiding caffeine before bedtime, getting in regular exercise, regular movement, keeping a regular schedule. This is really important. These neurodegenerative diseases, for some reason, often seem to push people towards a more night owl kind of schedule, where they're sleeping later and later in the day, they're taking naps throughout the day, and then they're awake all night. That's not good for brain health. And I've had people go, well, but they're up the same number of hours, does it really make a difference? It really does. All of the evidence tells us it really does make a difference, and it really makes a difference to caregivers and caregiver strain. So we always want to try to keep people awake during the day, asleep at night, and talk with your healthcare professionals about how to do that for your loved one. There are some medication treatments that we can use. I'm not going to go into them. These are in your slides, but these really depend on each person and their individual sleep issues, other medicines that they're on, other health conditions that they might have. So as I mentioned, daytime sleepiness, sleeping throughout the day is very common. So we want to try to rule out things that we can treat. If the person is up all night, then sure, they're going to be sleeping all day. If they're up all night and sleeping all day, we are not going to succeed in trying to completely swap their schedule overnight. It's not going to happen. It didn't change all the way overnight. We're not going to fix it overnight. If anyone has traveled across time zones, especially more than 4 or 5 time zones, you know what that jet lag feels like. Trying to change someone's sleep schedule is very similar. We need to do it very gradually. We want to make sure that there aren't any other treatable factors making someone sleepy throughout the day, like sleep apnea at night, like depression or apathy. We also want to think about eyelid opening apraxia, which is a really unique symptom, most common in PSP, but we can certainly see it in corticobasal and MSA, which is where a person is awake, but they can't keep their eyelids open. And it could be one eyelid drifting, it could be the other. You may bring it to their attention and say, hey, Bob, are you awake? Yeah, I'm awake. But they just can't get their eyelids open. They may be able to help and lift an eyelid and both eyelids may open. They may need help from someone else. And so this is part of the neurologic disease. And often people are mistaken for being asleep and they're fully awake. They just can't actually get their eyelids to open back up. We want to make sure, particularly in folks with MSA, that orthostatic hypotension, so drops in blood pressure, are being treated appropriately because that can be a big contributor to sleepiness and fatigue. So there are medications that we can use to help with excessive daytime sleepiness. Like everything else, we need to balance those with the side effect profiles and the benefits and risks and that individual person's other medications and other medical conditions. So talk with your doctor, but there are things we can do. Separately to the sort of daytime sleepiness is this idea of fatigue, which is I'm not sleeping, I'm just exhausted. I have no energy. This is really common, and we can adjust medications around to try to treat this. Sometimes fatigue goes hand in hand with untreated or undertreated depression, and so we want to make sure that we're taking that into account and we're treating that too. I mentioned earlier about trouble swallowing. The fancy word for that is dysphagia. Often this starts as it just takes longer for them to eat their meals, or it just takes longer to swallow. My loved one, I just heard this morning. They used to toss back a handful of pills and just kind of swallow them dry, and now it takes a really long time to swallow pills. If any of that's happening, that's an indication of trouble swallowing. And the sooner we figure out where exactly is that problem, the sooner a speech language pathologist can come up with exercises and treatments and adjustments to help. This is critically important because if we're not treating the trouble swallowing, people are at very high risk of swallowing something down the wrong pipe, which leads to an aspiration pneumonia. It's a fancy word for swallowing food, liquid, something instead of going down into the GI system, into the stomach, it goes down into the lungs. It's one of the most common reasons for people with all 3 conditions to wind up in the hospital. It's one of the most common causes of death. So usually aspiration pneumonia doesn't come out of nowhere. Often if we look back, the person will say, or the family will say, yeah, I've noticed, dad's been coughing a lot during meals, or, we'll start choking. We want to know as soon as possible, get a swallow study. Your doctor can prescribe that. It's usually done by a speech language pathologist, and they can pinpoint where the issue is and work on it. Something that we hear a lot in our clinic is people having a really hard time with thick, dry phlegm especially first thing in the morning or late at night, having a really hard time clearing it. So cough reflex is really difficult. And sometimes it's just, we see people kind of trying to get it out and they can't quite do that. Especially in PSP, I hear this a lot. And there's not a ton of research on this, but many of these things are sort of what we've learned from our patients and families that have been successful, which is for sure a swallow evaluation and therapy. Sometimes things like an incentive spirometer, which is that silly plastic contraption that they might have you use in the hospital where you take a big breath in and you try and make the little ball sort of go up in the little plastic tube. You're trying to take these big breaths, blow out these big breaths. Sometimes people have used flutter devices, which you breathe into and out of, and it kind of vibrates, which helps to kind of vibrate the air passages and try to kind of shake the phlegm and break it up a little bit so it's easier to cough up or swallow down. Sometimes we'll have people use a suction machine, and that can be ordered as a kind of durable medical equipment through some forms of insurance, certainly through hospice in the US can provide a suction machine. And there's a little bit of evidence for papaya enzyme or papase, which is used and helps thin secretions in some people. So no big randomized controlled trials that I'm aware of, but may be helpful for some folks. And then medication-wise, over-the-counter guaifenesin, which in the US goes by the brand name of Mucinex, but is available widely. Store brand is fine, but the really important thing is it should be pure only guaifenesin. Often cough and cold medicines are packaged with other ingredients like DM or dextromethorphan or PE phenylephrine. In people with neurologic diseases, those can cause confusion and worsening problems. So pure, plain old guaifenesin, you just have to take a look at that package and look at the active ingredients. That can be very helpful for that thick phlegm. Sometimes nebulizer treatments and a suction machine, as I mentioned. One of the things that we look for the most in our advanced clinic is unintentional weight loss, both because to us, this is a sign that things are progressing and because it's often treatable. So what are the reasons someone might be losing weight? As I mentioned before, it might take longer to swallow food. Things might be getting caught. So if someone is having trouble swallowing, we want to evaluate that. We want to treat that. And there are lots of people who can be on that team, the speech language pathologists, dietitians, nutritionists. We may be able to alter the diet to include thickened foods, chopped up or minced foods. There are lots of sneaky ways to add calories in. Someone may be having dental issues or dental pain. And so if that's the reason why they're not eating or their dentures are fitting poorly, we want to get our dental colleagues involved. Often as these diseases go on, we lose sense of taste and sense of smell. So the foods that used to be delicious no longer taste the same. They're just not as appealing. I think this is especially important for care partners, especially if you're the cook in the family, to know it's not you, it's not your food, it's the disease. And it's okay to let your loved one add salt if they need to, add some hot sauce, add whatever they need to make things more palatable so that they'll actually take them in. And then overall, often people are on other diets. So maybe they have diabetes, maybe they have kidney issues, maybe they're on a cardiac diet and they're used to cutting things out. But as these neurologic diseases take over and we're having trouble with swallowing, trouble with other these issues, we may actually need to relax some of those restrictions because the unintentional weight loss becomes much more of an immediate problem than worrying about some of those long-term risks. Because when people are losing weight in these conditions, it's not the weight loss that the rest of us want, right? It's not let's get ready for bathing suit season kind of weight loss. It's muscle mass loss. And so if people are losing muscle mass and they start to tip, they start to fall, there's less muscle to help catch themselves. So their risk of falls is higher. Their risk of needing help to transfer in and out of bed, in and out of a chair is higher. And if they fall, there's less cushion to protect the hips, to protect the pelvis and other bones from breaking. So we want to involve all of these colleagues to help. Sometimes it's just that care partners are so sleep deprived. They're doing so many things. They're shuttling to so many different appointments that, we sort of go, well, we don't really eat breakfast. We sort of have a snack for lunch and we have one big meal in the day. And everyone may be happy with that. and it may not be enough calories still. So it doesn't mean as the care partner, you need to go, okay, no, I'm failing at this. No one is failing at any of this. That's a time to say to all those folks who say, let me know if I can help. You can help. How about you order groceries? How about you pick up this? How about you, send a meal every other Tuesday? Whatever that is, that's an easily delegated task to let someone provide food. And it's a very clear, tangible way for people to help when those are often hard to find. We'll talk briefly about the autonomic symptoms. So drooling is very treatable. We think about drooling sometimes and think, oh, maybe it's just a cosmetic issue. For a lot of people, this is contributing to trouble with swallowing. It's very treatable. We can try some first-line things that are simple, like chewing gum, if that's safe, if the person is able to keep that and manipulate that in their mouth. But otherwise, our safest and most effective treatment is, like I mentioned for dystonia, using botulinum toxin injections. So that, and many movement disorder neurologists, many neurologists can do that. Runny nose is a common issue, especially around meal times. This is treatable with a nose spray in about half of people, so it's worth trying. I'm not going to spend too much time on constipation because I could give you a whole hour on that, but constipation, very important, very common, very treatable for many people, but folks often go in a vicious cycle, which is we kind of let the constipation build up and we wait till it's been 3 days, 4 days, we're getting uncomfortable, and then we start taking all of the stuff, and then we have diarrhea, and then we go, wah, that was not what I wanted, and we pull back on all of those things, and around we go. So in these conditions, the gut is moving very slowly, stool builds up, and it gets very hard and very difficult to pass. And when you first start taking stool softeners or laxatives, they soften up the newer, softer stuff first. It sometimes scoots around the hard stuff that's really the problem. And when people get that scoot around or overflow diarrhea, they stop the medications or the treatments. But the problem, the really hard stool, is still there. So the secret is staying really well hydrated. Any kind of movement helps with gut movement, and adjusting the diet. So trying to get in fiber in your diet, better if it's coming from food than from supplements like Metamucil, Benefiber, Psyllium. And then sometimes prebiotics and probiotics, there's some evidence around those. We have a lot of people that do well with senna, which comes in pills, comes in a tea, coffee can help. And then people have a really hard time sometimes relaxing the pelvic muscles to actually have a bowel movement. So raising the feet just up on a step stool actually helps change the way the muscles are in the pelvis and lets you have a bowel movement more easily. So getting a step stool that has non-slip bottoms, so it's not a fall risk in the bathroom, can really help. Beyond that, our safest and most effective treatment for constipation is Miralax or polyethylene glycol. Your system doesn't get used to it. It's safe. This is what pediatricians use for kids for years who have chronic constipation for various reasons. But it's really important that if you start it, you continue it at a steady level, because people will often get that overflow diarrhea first and then they stop. But it's actually, you got to start it and stay on it. And then there are more treatments that often our GI or gastrointestinal colleagues can help with too. I'm going to skip through some of the rest of this, but you'll have it in my slides because I want to make sure we have time for questions and a little bit of time to talk through sort of palliative care. So what we know is that as these disease progresses, and apologies, this should say PSP and MSA and corticobasal, caregiver burden rises, motor severity increases, and cognitive changes and hallucinations can happen. The main causes of hospitalization in these conditions, as we've talked about, infections, falls, dehydration are among those high risks. And the reasons for people being placed in a nursing home are those same things, that the mobility is getting worse, hallucinations, if they're happening, can get worse, cognitive changes, and increased caregiver strain. And we know that people with Parkinson's have higher risks in a nursing home than people who don't have Parkinson's or people who have Alzheimer's. There's very little data on people with atypical Parkinsonism in nursing homes, but I can tell you from experience, most nursing homes have very little knowledge, if any, about these conditions. And what we know is as time goes on, there's a very high degree of unmanaged or undermanaged symptoms in people with chronic illness. Sometimes it's very hard to get communication from one specialist to another. There's a lack of coordination, and there's a need for planning for the future. And patients with these illnesses want appropriate treatment of their symptoms, including pain. They want a sense of control, of communication. They want their care coordinated. Many people express that they want to avoid inappropriately prolonging the dying process and relieve burdens on their family while strengthening the relationships that they have with their loved ones for as long as possible. And we know that caregivers really want the same things. They want their loved ones' wishes honored. They want their loved ones and themselves to be listened to. They want to be included in decision-making process, but also have practical help. What do I do when this happens at 2 a.m. when XYZ happens? Who am I supposed to call? And so in big studies that look at what does everyone want, right? The vast majority of people, if they're asked, what do they want their life to look like if they're coping with a serious illness or they're facing the prospect of dying, the vast majority of people say they want to pass at home. But yet, in the US and in most places in the world, the vast majority of people pass in hospitals or in nursing facilities. So it's like we sort of have this blueprint of we want one thing, and what actually happens is something else. And it seems like we kind of need a bridge to get us there, right? And so this ladder to me is palliative care. Palliative care often is thought of as kind of a taboo topic. There's a lot of stigma around it. But what I want to read you is the American Academy of Neurology published this statement defining palliative care. And it says, palliative care is an approach to medical care that aims to improve the quality of life for patients with life-altering illness and their families through prevention and management of physical, psychosocial, and spiritual suffering. Palliative care does not seek to hasten the end of life, but to help patients have the best quality of life for as long as possible, while recognizing the inevitability of death and providing comfort and dignity when end of life arrives. And what I often will stand on my soapbox and say to people is, until we have cures, everything we do in this field is palliative care, whether we call it that or not, because everything we have right now is trying to alleviate suffering and treat symptoms and help people have their best possible quality of life. So it's palliative care, whether we call it that or not. But when we think about palliative care and the way that it's typically defined medically is specialized medical care for people with serious illness that focuses on providing relief from symptoms and stress to improve quality of life, not just for the person with the diagnosis, but for their family as well. And this takes a team. That team can look different, but it takes a team. So primary palliative care means that care, symptom-focused care, delivered by a non-palliative care specialist. So it could be your friendly local neurologist, could be your primary care physician. They might not realize it though. They might not think of themselves in that way. And another question that we get is, well, when is it time to involve palliative care? And I love this chart by Dr. Fleger and colleagues that really shows there's no right time to start palliative care. It could be any time, because this chart is supposed to sort of illustrate that the need for palliative care, for whole person thinking and symptom control and all of those forms of pain, not just physical, but psychosocial, spiritual, comes all throughout these diseases at the time of diagnosis, as we lose certain abilities like the ability to drive, as we need more assistance with dressing, and as symptoms are declining. So palliative care can apply to any age of person, any stage of disease, including in diseases where we don't have great staging systems, and can coexist with curative treatments if they exist. So there are many forms of cancer that are treatable, and people get those treatments and are also seeing palliative care specialists at the same time. But people often conflate or think that palliative care and hospice are one and the same thing. So it's a funny Venn diagram. Palliative care is a big circle. This big blue circle is all palliative care. Hospice refers to a specific portion of palliative care. So hospice in the US refers to medical care and support for person and caregivers when curative measures have been exhausted and at least two healthcare providers feel that the person's prognosis is 6 months or less. None of us have a crystal ball. And as I told you, the staging systems are not very reliable at this point in time. So this is often our experience, our expertise, and it's our best guess. And many of us are wrong in both directions all the time. There are people who I have admitted to hospice thinking that we have weeks to months, and they've lasted years. And there are people who we've talked about hospice, and I thought, we're not there yet. We've got lots of time, and they've lasted weeks. So in general, we need better studies, we need better research, we need better information to help you know what's coming. I would say for a lot of people, I think they worry that their healthcare professionals are withholding information from them. And I don't think that's the case. I think we don't have the information yet to be able to provide. So in the US, and again, this varies by country, but in the US, hospice is an insurance benefit. So just the same way that insurance covers medications or certain services, insurance is covering hospice. And if they do that, what that means is you have access to an interdisciplinary team of hospice professionals, physicians, nurses, other therapists, that they will provide certain home medical equipment like a hospital bed. They will take over providing the medications. They will offer some respite care, but not caregiving services 24/7. But there is a 24/7 number that you can call that someone will always answer to help you navigate if there's a change at 2 a.m. What do I do? Do we go to the ER? What do we do about this? Any hospice agency has to have an affiliation with an inpatient hospice unit so that if the needs of a person in hospice are greater than what can be taken care of at home, they can be moved to an inpatient unit. And any hospice agency has to offer bereavement support, meaning support for the loved ones when that person with the diagnosis has passed for at least 13 months after the person's death. So this means the nitty-gritty of this, hospice will supply incontinence supplies, wound care, oxygen if it's needed, a hospital bed. The team from hospice varies, but typically that looks like a nurse coming out weekly, a social worker maybe coming out weekly, some medications, but hospice will not just continue what the person was on before. I mentioned that we don't have great hospice guidelines. I'm not aware of any reliable guidelines in PSP, MSA, or corticobasal, and I do this every day. We use some of the hospice research and prognosis guidelines for people with Parkinson's, and those include specifically unintentional weight loss, where people are really struggling to take in their caloric needs. They're getting dehydrated, their body mass index is less than 18, or they've lost more than 10% of their prior weight over the course of 6 months. If that's happening, that's a trigger to me to think about hospice. If the person in the last year has had more than one episode of aspiration pneumonia, falls where they're breaking a bone, if they've had a urinary tract infection that's so severe that it's gone to the kidneys or it's gone to the blood, or they have a very severe pressure wound, those are also reasons why we might think we are in the latest stages, we're in the end stages, or we have months left, and we should be thinking about hospice. Medicare in the US has specific hospice guidelines for dementia that's not disease specific, but in order to qualify for hospice based on the dementia guidelines, a person has to meet all of these things. They cannot walk, they cannot dress, they cannot bathe without assistance. They have both bowel and bladder incontinence, and they really cannot speak. And for many people with PSP, corticobasal MSA, some people may eventually meet these criteria, but certainly not everyone will. So often, if the physician feels like the person with PSP, MSA, or corticobasal is appropriate for hospice, it takes that neurologist or that physician arguing with hospice to say, no, you don't understand these unicorn diseases, but I do. And here's why my patient requires your services. And that neurologist can stay on board if the hospice team does not have neurologic expertise, which most do not, to keep fighting and advocating for that person. So before taking the step towards hospice, a couple of important things to know, which is that most hospice agencies do not offer physical therapy, occupational, or speech therapy. They get a certain amount of money from Medicare to use for each patient, and that money has to cover the nurse, the social worker, medications, supplies, so that it's not enough typically to cover therapies. So for a lot of people, giving up physical therapy or occupational therapy is a big sticking point. So knowing that going in, I think is really important. Know that you can interview different hospice agencies. You have choice here. And there are questions online that people can use to sort of interview agencies the way that you would for anything else. I think it's really important to know that hospice services in the US provide a nurse, provide a social worker about weekly coming in, provide supplies, but no paid caregiving. So I think one of the hardest things is I often have families that will tell me like, okay, Dr. Fleisher, I'm ready. Like hospice, I think we need hospice. They're going to come, right? They're going to be here all the time. And they're not going to be there all the time. It doesn't negate the need for any caregiving you've had so far. This is just an extra layer wrapping around, but not all the time. We often need to minimize medications because, again, the hospice budget is very limited. So anything that they think is not immediately helping quality of life, they will get rid of. So things that make sense, getting rid of certain vitamins, certain supplements, cholesterol medications, other things like that that are preventing things 10 years down the line from now, we don't need those anymore. We want to focus on things that directly today are giving a benefit to the person taking that medicine. If there are expensive medicines that someone is on, often those won't be covered by hospice. So for my folks, I will try and get them a 90-day supply of any of those things before hospice starts. Similarly, botulinum toxin injections, Botox injections, even though these help with comfort, hospice typically doesn't cover. So getting those right before referring to hospice so that at least lasts us 3 months. So how do we try to advocate for some of these things? The secret is advanced directives. So what does that mean? Advanced directives include things like naming a healthcare power of attorney, putting that down on paper as a legal document, writing out a living will that says, here is what I want, here is what I don't want. And it could be completing forms like a do not resuscitate or do not attempt resuscitation order or a MOST or POST form, depending on your state or your country. And these can be really hard conversations to have. And I will say that even within my own family, as someone who does this and talks about this all the time, it often feels like it's too early to talk about these things until it's too late. And as a person with a serious illness, as a family member with a serious illness, one of the biggest gifts you can give to yourself and your loved ones is to make your wishes clear so that in the event you can't communicate those wishes, you have peace of mind that your loved ones know what they are and can follow them, and your loved ones don't have to question whether they're doing right by you. So advanced directives are your blueprints for building that ladder between here's what I want, but here's what normally happens. So it's a legal document where you express the kind of healthcare you want to receive and who will make decisions if you can't. So a living will usually states what I want. A durable power of attorney for healthcare or a healthcare power of attorney is who I want speaking for me. And that person is not, I think that person would make good decisions. I've seen them make good healthcare decisions. I'm sure they'll figure it out at the time. That person needs to know that they are your decision maker, and you should tell them what kind of decisions you want or don't want them making. A MOST or POST form, and this is fairly US specific and state specific, is kind of a shorthand document only to be used in emergency situations. People often hear these things and they think DNR or do not resuscitate. And that is one small piece of this puzzle, but it's certainly not all of it. And I think it's important to think about these things. And this slide, I want to give credit to Dr. Heather Leeper for putting together this slide, is that often we think about advance directives. We might write out a living will and say, okay, if this were to happen, I would never want to be kept alive. So some people say, I would never want to be in a wheelchair. I'll do everything to live as long as I can, even on a breathing machine. You know, we may have very strong opinions. And as time goes on and abilities change and symptoms change, our views on quality of life may change. So making sure we have those documents and we revisit them over time to say, does this still fit? Right? It's like taking out that old sweater and trying it on and going like, this looked good before, but it's not really a good fit anymore. So revisiting those documents is important. Healthcare power of attorney forms are state specific. Every state in the US, there are living will forms that you can look up, but a living will, you can use a standard form or you can write your own. So I have some people where their living will is a Post-it note and it says, under no circumstances should you XYZ. So it can be that casual or it can be very formal and written out with an attorney. You can cancel your living will at any time by telling someone, by canceling it in writing. And you don't have to do this on your own. So I put in here 2 really helpful websites I really like that walk people through these conversations. And I'll point out the conversationproject.org. If people are familiar with Dr. Atul Gawande, who's written several wonderful books, this has come out of his work. And there are conversation project documents that help you talk through these decisions with your loved ones, including people with dementia. This is just an example of that MOST or POST form. These are documents that are meant to live on your refrigerator, quite literally, so that in the event that you or your loved one were to be found down, and emergency medical technicians, 911 is called, EMS is called, and they find the person down, the paramedics are trained to look at the fridge to see if you have this emergency documentation. And it is literally shorthand that says, if I am found without a pulse, number 1, right? No pulse means your body, you're dying, and you will die unless an intervention is taken, right? The default position in healthcare is to try to do everything to bring you back. So if that is your desire that the EMS do CPR, puts in a tube to help you breathe, you don't need one of these forms. If you're in a hospital and your desire is for them to do everything, you don't need one of these forms. The default is doing all of those aggressive interventions. But if you say, I would want to go peacefully, I would not want chest compressions, I don't want my ribs cracked, I would not want to be shocked, I would not want a tube under any circumstances, putting this into a document and having that document visible, having whoever is your healthcare power of attorney know that you have this document and that they have a copy is really critically important. And then there are other decisions that can be made on this document that also help. It's neon so that the paramedics see it. Okay, so we've talked about a lot of different things. I know we've gone over time. In summary, I just want to touch on the fact that we talk through all of these things. Not everyone gets all of these symptoms at all, but we talk about them because they are treatable. And palliative care is not a dirty word. Palliative care means treating complex symptoms with a focus on quality of life. And that is typo, I'm sorry, but PSP, MSA, corticobasal syndrome are very unpredictable, but planning is possible and strongly recommended. Everyone has goals for their own care, and those goals change over time, but we cannot achieve them until we put them into words and until we tell the people who we trust what those wishes are so that they can help carry them out at that time. So palliative care, hospice, advanced directives are not dirty words. They're not scary, I hope, but they're actually really underused tools to help you and your loved one achieve your goals of care. So with that, these symptoms are treatable. There is always, always, always something we can do until we have a cure. And so many people are working towards that. But until we have a cure, there is always something we can do to try to make life better. So please use the teams that you have. If your team is not helping you, reach out, build a new team, reach out to CurePSP, reach out to the support groups, to the community. This is an amazing community that no one asks to be part of. But now that you're in, reach out to the people around you. They are tremendous sources of wisdom. So with that, I thank you so much for your attention and for staying on long after the allotted time, and I will stick around and take some questions.
Oh my gosh, thank you so much for you going over and just giving, I mean, any one of those slides alone could have been an hour talk because you're talking about such complex things. So thank you so much, Dr. Fleischer. Knowing that we're over time, I do want to make sure that we are able to get to some questions that came through the chat, that came through registration. So as my colleagues put in the chat, if you're not able to stay for our Q&A now, this is recorded. You can watch it later. But if you can stick around a little bit longer, Dr. Fleischer.
I can stay around for probably another 15 minutes or so.
Okay,
my other meeting was canceled, so we're good.
Okay. I'm trying to think of where I want to start with any of this. First of all, I want to acknowledge there's been some good back and forth in the chat around, and some people just like, not even questions, just sharing their experiences with one another around Botox. Not sure if you want to add anything to that, but some of the things that are coming up, one person shared, actually two people shared that their loved one's knees look really bad and how hard that can make it for them to move around. And then somebody else said that they had done Botox for their loved one in their arms and their hands, and it really helped. And then somebody else said that they did that and it hasn't really helped. So two things around Botox, around dystonia that maybe you can speak to that came up for me. One is how it seems it's not just about like management of pain or decreasing risk of contractures. All that's really, really important, but it also has this impact on how people can move around. Like even if getting it in an arm to get your shirt on easier.
Exactly. Yeah.
And then the second thing that maybe you can speak to around that too, because one person said that Botox really didn't work for them, is like how effective is that from person to person? Is that the kind of thing that you have the ability to like increase doses, or should you try it a few times to see if that's the right treatment for you?
These are all such great questions. So I guess I'll take the last one first, which is to say it is variable from person to person. And you also, and it's really hard to know because typically we start as healthcare providers, as people doing the Botox injections, we start with a low dose because we don't want to overdo it. So we start with a low dose, and because of insurance regulations, we can't usually give it more often than every 3 months. So that first dose may not do a lot. We hope it does. We're not trying to underdose people, but we're trying to start with a safe low dose. And for some people that works. For other people, they come back 3 months later and go, I didn't see any difference. It doesn't mean that it won't work, but it means we should increase it. It might mean, so Botox gets injected into different muscles. And so it may mean that we need more in this one muscle and less in these other 3 muscles, and a little bit, we need to add some in the 4th and the 5th muscle. It really is both an art and a science. So you really want to be seeing someone who's very familiar with doing injections for dystonia. So personally, even though I'm a movement disorder specialist, because I trained in several other areas, I'm trained in Botox for drooling. I am not trained in Botox for complex dystonia. So I yield that expertise. I have colleagues where if my family needed that, I would never be the one to do it. I would, want someone who does this all the time and can go, wait, this muscle responded this much. Okay, we need to tweak by this. So typically movement disorders neurologists and some physical medicine and rehabilitation docs or physiatrists have a lot of experience with botulinum toxin. And so if it hasn't worked, especially if it was just the first time, I would encourage you, tell the physician who did it, let them know, see if a higher dose will work, see if a different pattern will work, and it may be worth getting a second opinion. The other thing I'll say is that there are arbitrary limits that insurance will sometimes place on how much a person can get. I was on the phone this morning doing a peer-to-peer with insurance companies about a patient with corticobasal syndrome, and they thought, no, they've tried a low dose before, and it says in the chart it didn't work, so we're not going to approve a higher dose. And that's just wrong. So the insurance company is not a movement disorder specialist. They're not a neurologist. They don't know. So sometimes that takes fighting. It took a 15-minute phone call and they approved a higher dose. That may be a fluke. It's not usually quite that easy. But it takes advocacy, as all of our care partners know, especially when we're dealing with rare diseases. So saying, to someone, I'm happy to send you the papers talking about how we treat dystonia and pain in someone with corticobasal syndrome, because there's research on that. And we absolutely use higher doses of botulinum toxin. They went, oh, okay. Yeah, don't send us the papers. Don't make me read more. I'll check the box. So speak up, advocate for your loved ones, advocate for yourself, get a second opinion. And yes, so this movement, getting that arm up and back, sometimes that's difficult because of rigidity, just stiffness of the muscles. Sometimes the muscles are actively pulling against each other and there's dystonia. Sometimes there's apraxia, which is that we lose sort of the motor pattern of like, these muscles need to fire in this order to do that movement. And so getting an arm into a shirt, into a sleeve, into a jacket can be really, really hard. Sometimes Botox can help with that. The other thing I would add is thinking about adaptive clothing. So if you go online, if you go on Amazon, if you go on whatever site and you type adaptive clothing, this is a whole different world than it was even 10 years ago. There are mainstream clothing companies that are realizing that everyone is different and not everyone can put on their shirt or button their collars or put on and bend down to put their shoes on in the same way. And that instead of saying, all right, you have to, buy clothes that are boring and look like, they came from an institution, they are making their clothes more adaptable to people with different abilities. So yes, we can use medications to help, but we can also find ways around, different clothes and things that don't look different, but make it easier for people to do all the things that they want to do. So I think those go hand in hand.
So much of this does, right? A lot of how we care for these diseases, it's like pharmacological approach as much as possible, and lifestyle management, rehabilitation approaches too, go hand in hand.
100%. The secret is the and.
Yeah.
Right? It's never, I don't think there's any one symptom where we have one clear treatment and that is the only thing for that symptom, right? It's always and. And so many of the tips and tricks that I will tell my own patients and families are coming from other patients and families going, do you know about this thing? I just learned about a new shoe earlier this week and was like, that's so cool. People can step their foot in, in a different way. And I wouldn't know about it if people didn't share it. So if you find something that's working for you or your loved one, please tell other people in the community, please tell your healthcare professionals so that we can amplify that and share it to other people.
Yep, absolutely. We always love learning about tips and tricks from our community members. Okay, so I guess sticking along the lines of medications and treatments, we've gotten a couple of questions in the chat around carbidopa, levodopa, and I'm going to make it sort of a bird's eye view of this question of, can you speak? So we know with the atypical Parkinsonian conditions that a lot of times not having a robust response to carbidopa, levodopa is what can kind of tip a neurologist off to this might be PSP, CBS, or MSA instead of Parkinson's disease. But we also know that carbidopa, levodopa is sort of the first line treatment for motor symptoms with these diseases, but some people report not having any improvement on it at all. And so can you speak to how, sort of general dosing works with these? Like, is that something that people should expect to increase over time? Or if it didn't work for them in the beginning, does that mean it's never going to work and we just don't use levodopa? What does that look like with these diseases?
These are great questions. This could be a whole talk. So
I know.
I will try and thumbnail it very quickly. But so it's still our most effective and our safest of the medicines to try to help with slowness, stiffness, walking. And the reason that it is both the safest and the most effective is because once levodopa gets past the blood-brain barrier, which we can almost think of as like your brain is kind of wrapped in saran wrap, essentially, and it's hard to poke a hole and get medicines through it. The carbidopa helps us kind of poke a little hole, get the levodopa in. The carbidopa otherwise, we don't care about. So it's like when you see the space shuttle take off, right? There's booster rockets to get it where it needs to go. We don't care what happens to them. They fall off, okay? So the carbidopa, no one really cares about, is gone. The point is to get the levodopa where it needs to go. And levodopa, once it's in your brain, is dopamine. And dopamine is one of the chemicals in the brain that starts to deteriorate, that we lose, that causes the slowness, the stiffness. And so it makes sense that giving it back should help with that. It's like if people are B12 deficient, we give them back B12. If you're dopamine deficient, we give you back dopamine. But that's not the whole story, especially in these atypical Parkinsonism conditions, is there are other neurochemicals, there are other areas of the brain beyond sort of the dopamine areas that are deteriorating. And because of that, either because those other areas are involved, or because of changes in sort of the dopamine chemistry and response system, that the levodopa may not be as we think about people with these conditions as being not as responsive to levodopa, sort of taking them one by one. In folks with PSP, often we don't see a response at kind of our usual starting dose, which is typically starting with a 25 100 milligram tablet. 25 is the carbidopa, we don't care. 100 is the levodopa. And often people will start with like half of a tablet once or twice a day, gradually working up to one tablet 3 times a day. And the 3 times a day has to be spaced out during the hours you're awake. So one of the biggest things I see coming from people in the community is, I tried levodopa and it didn't work for me, so I must have an atypical form of Parkinson's. And I ask them, how do you take it? And they say, I take it with breakfast, and then I take it in the afternoon sometime, and then I take it at bedtime. And what we find is that afternoon sometime dose often is not happening because people are really busy during the afternoon. So people are people. People forget to take meds, including meds like carbidopa, levodopa. And if you're taking it at bedtime, you don't need it for the most part while you're sleeping. So you're basically peeing out that dose. So people think that they're taking one pill 3 times a day, but effectively they're taking one pill in the morning. And levodopa, like an ibuprofen, is in your bloodstream and in your brain for about 4 hours max. So if you take a pill at 8 a.m., you are on your own from noon onwards. And so sometimes people will go, yeah, well, it didn't do anything because I'm really slow in the afternoon. And it's like, you're at your baseline. It's not the levodopa not doing anything. It's doing all that it could, but it only lasts a certain amount of time. So in people with PSP, we will often start with that, half tab, working up to 1 tab 3 times a day. But we typically don't see much at that dose, and we'll slowly inch our way up and up and up, trying to sort of squeeze some efficacy, some help with stiffness or slowness out of that drug. And we worry far less in people with PSP about some of the other complications. It's very rare to see dyskinesias or extra kind of fidgety movements. It's very rare to see hallucinations. And those are some of the things that Uncle Google would tell you to worry about. Uncle Google did not go to a very good med school and didn't graduate. So please ignore Uncle Google. Folks with PSP, we have room to push the dose. And often we will see some response for some period of time. That could be months, that could be years, with 600 milligrams 3 times a day, 900, higher doses than we typically think about. And that's okay. If you respond, there is no maximum dose. It's the dose that works for you. So that's kind of PSP, and that holds a bit for corticobasal as well. In people with MSA, it's a little bit different because the old teaching used to be that if we see dyskinesias, extra fidgety movements after people have taken levodopa, that only happens with Parkinson's disease. And typically that's years in. But what we now know is actually people with MSA are more likely to develop dyskinesias at low doses and early. And it's often kind of facial and sort of neck. And so if I see that in someone early on levodopa, that to me makes me think, are we really Parkinson's, or could this be MSA? So we certainly use levodopa. It can absolutely be helpful, but we may get limited by dyskinesias early and even at those very low doses where we wouldn't expect to see them in someone with Parkinson's. And levodopa and all of the other dopamine-related meds can drop blood pressure a little bit. Typically, we don't really feel that. But if you have MSA and you have orthostatic hypotension, you may have big, wide swings in your blood pressure all the time on your own as part of the disease. And if you're already kind of doing this and the levodopa drops you even a little bit more, you may not be able to tolerate even low doses of levodopa. So I have a lot of folks where we're like, well, do we keep trying to get them to tolerate the levodopa and just give them meds to boost up their blood pressure? Or, do we kind of pull away? And it really is an individual person by person decision based on how that person's doing, what other medications they're on, what their daily life looks like. So we always try it unless there's some glaring reason not to, because it offers us our best chance at help with mobility, but there are individual considerations by disease and by person.
Right. So I have about 200 more questions that I could ask you, but do we have time? Do you have time, Dr. Fleischer, for one more? Because there's one. Yeah. Okay. Because there's one more it's also a big question, like all of these are, but I feel like I'd be remiss not to ask, considering the topic. And it's the concept of stages, and which I know you talked about early on, but I'd say, what to expect, how to prepare. These are questions we get all the time. People are looking for guidance. A lot of times people ask, what stage am I in? And I know that you spoke to that, but like in the registration, one person in particular wrote, and so I made a note of this. They said, I want to be more prepared, but it feels like we can never get ahead of things. And so much of what you talked about today is such like practical, helpful information. But a lot of times it's sort of like, look for these things, and if they start to happen, here's some things we can implement. What advice would you give to someone about thinking about the stage they're in and sort of what to look for down the road and things they can put into place now to help them, down the road once they're in a little bit later stages?
Yeah.
If that question makes sense.
It does.
I tried to formulate like 6 questions into
I appreciate it. I think swallowing as kind of, I don't know, I think of it as sort of a very unsexy thing to think about. But how a person is swallowing and whether they're losing weight, whether it's just taking 3 times as long to eat, what was on the dinner plate before as what's on there now. If that's changing, that's something that sort of, if we don't address it and take some steps to try to fix it, progression may go really quickly. Whereas it is, I sort of think about it as like that's kind of an action point. Like we can intervene there. So if you are noticing that as a person living with the disease or as a care partner, bringing that up, putting that at the top of your list when you go in for a visit and saying, this is really important. Sorry, 2 more minutes. So I think that's really important. Weight loss that's unintentional kind of goes with that. I think that's really important. Falls are really important, and why the person is falling. Are they falling because they're lightheaded? Are they falling because they're sort of getting this dazed look on their face that often makes us worry about orthostatic hypotension? Are they falling because they're kind of bumping into things? Are they, what is it that's making them fall? If you have a sense of that, right? And bring that to the attention. And I think it speaks to coming into a visit and knowing that, the neurologist that you're seeing, whoever you're seeing, is going to have questions that they want to ask you. I'll always have stuff on my mind that I'm worried about, for that particular person. So you may not get through a list of 10 items, but if you've got the top 2 or 3 things that you want to talk about for the visit, put them out there first. Yeah. We often joke about the hand on the door comment. Someone will come in and they're like, well, we did this. We want to talk about constipation. We want to talk about this, blah, blah. And then I'm, walking out the door and they're like, do you think, if that's on your mind, bring it up first. It's okay. There's no question you're going to ask that we haven't heard. These questions are hard. We don't get a lot of training in medical school or residency on how to tackle these difficult conversations. But if you feel like you're not getting answers, if you feel like you're not getting resources to help support you, we may not have clear answers, but if you feel like you don't have a team that's supporting you in your search for answers and trying to give you the information that they have, you may want to look for another team, right? Or, reaching out to CurePSP, seeking, advice from others in your community, I think can be really helpful. But what are your priorities?
Sorry, I didn't mean to over talk you. I was just going to say making sure that your priorities and top questions and concerns are guiding that appointment with your provider. So, okay, and also looking out for those big, risks of complications, trying to get ahead of those as much as possible and, assessing them and then making accommodations accordingly in order to minimize that risk. And the advanced directives play a big role in that as well. Okay, you've so over time. Go to whoever knocked on your door. Thank you so much.
It's my pleasure. Thank you for organizing this, Jessica, and everyone behind the scenes. Thank you so much to everyone in attendance and watching. Thank you. Thank you for doing the hard work that you do every day living with these diagnoses. So you are our inspiration. You are what make all of us go on and show up to work every day. So thank you.
All right. Talk to you soon, Dr. Fleisher. Thank you. All right. And to everyone out there who hung on for an extra 33 minutes now, just a couple, less than a minute of closing remarks here. I want to say that if we did not get to your question today, and we probably didn't because there was a lot to cover, please email us, okay, at info@curepsp.org, and we're going to do our best to get you the right answers and resources from there. Our next virtual program will be our wellness workshop on April 2nd and April 3rd. Please check out the agenda, which, by the way, includes Dirk, who is the chaplain at Rush that Dr. Fleisher mentioned. He's the one that does dignity therapy, so we've asked him to come and speak. Anyway, check out the agenda and register at psp.org/events. As a reminder, not only is this going to be on our YouTube channel, but our YouTube channel is a wealth of archived educational content from past webinars and family conferences. So a lot of the stuff you all have asked about, even just today on swallowing, we have a webinar on swallowing. On nutrition and diet, we have one on nutrition and diet. So please check that out. And lastly, as always, it's important to underscore that we're able to offer these webinars and all of our resources and services because of your support of CurePSP's mission to raise awareness, build community, improve care, and find a cure for PSP, CBD, and MSA. So thank you for your support. Also, thank you for being here today and showing up for yourself and wanting to learn and wanting to prepare and navigate all of this as best as you can. Like Dr. Fleisher said, you are why we are doing this, and we are here for you. So you have a good rest of your day, and we will talk soon. Thanks, everyone.